Before we talk about each of the conditions of gallstones, as far as the complications that can arise, let's go over what exactly a gallstone is. So gallstones are going to form when there's an imbalance in bile concentration. Remember from before, we talked about bile being 95% water. It also has bile salts and acids, cholesterol, bilirubin, and other compounds. So I want you to view this as a scale between water and bile salts, helping to dilute the bile and decreasing your risk of gallstones, versus these other compounds, cholesterol and bilirubin, which is going to concentrate the bile and increase your risk of gallstones. So there's kind of this back and forth between those two compounds versus the other two. So what causes gallstones? Well, gallbladder stasis can. If bile's not moving, you give it more time to start to concentrate and form actual precipitated masses. As I just mentioned, if you have any decreased water or bile salt levels, that's going to concentrate the bile, and that can cause gallstones. Or on the other hand, if you have increased levels of cholesterol or bilirubin, that can also cause a problem. So gallbladder stasis, let's talk about the three causes briefly. Gallbladder stasis would prevent bile excretion, and this can lead to an increased risk of stones. So if you could imagine, here's our bile. If it's flowing out this outflow tract, then we have no problems. But the problem is if it's just sitting there for too long, you can start to develop gallstones. What causes gallbladder stasis in the first place? Oh, pregnancy is a common contributor, and that's because progesterone promotes gallbladder stasis, so you're at higher risk of gallstones in pregnancy. Another thing is total parenteral nutrition, which just means that all your nutrition's coming in through an IV line. Nothing's coming in through your GI tract. This is in people who are very sick. And in TPN, the lack of nutrition in the gut decreases our CCK release, which will subsequently decrease our gallbladder contractions. So normally, if you or I had some food, it would enter the duodenum, that would end up in the duodenum. It would stimulate CCK, excuse me. Remember, amino acids and fatty acids can stimulate your eye cells to secrete CCK or cholecystokinin. That cholecystokinin will ultimately interact with the gallbladder and cause the gallbladder to contract, and you'll end up with bile in your duodenal lumen. The problem with total parenteral nutrition is that you lose any sort of fatty acids or amino acids in your gut. So your eye cells are not going to be producing that CCK, which will make it so this bile is not contracting out and you can form a gallstone. Another cause of gallstones is decreased water or bile salt or acid levels. So if either of these are reduced, you're going to increase your risk. So for decreased water, that should be somewhat straightforward. Any condition that causes dehydration, or yeah, any condition that causes dehydration will increase your risk of gallstones. And for decreased bile salts and acids, there's a few conditions to keep in mind here. One we've talked about in both the small intestine and colon lecture is Crohn's disease. And so Crohn's disease can decrease bile acid reabsorption. And we actually talked about it earlier in the physiology section, where bile, keep in mind, bile is not reabsorbed with the fat micelles here in the enterocytes, and instead it goes all the way down to the terminal ileum for reabsorption. And in conditions like Crohn's disease, you lose a lot of your architecture of your terminal ileum, and so you're not able to absorb bile, and you can get bile salt deficiency. And so that's why Crohn's has an increased risk of gallstones. A cystic fibrosis can also cause decreased bile acid reabsorption. What's happening here is that in cystic fibrosis, you don't have, oftentimes there's a lot of viscous fluid in your pancreatic duct, which we talked about, and that's why it's one of the common causes of pancreatic insufficiency. So if we don't have enough pancreatic lipases in our duodenum or in our GI tract in general, what's going to happen is that we don't even, we aren't even able to break down these fat globules into these smaller micelles. So you're going to end up with a lot of fat globules traveling through your GI tract, and bile will still be attached to that. And if bile is attached to that, it's not going to be able to get reabsorbed at a healthy rate. And without the bile, salts and acids, you're going to lose a lot of the ability to dilute your bile. Liver cirrhosis can also cause this because of decreased bile acid production. Remember that liver creates bile. So if there's any defect in this, that could technically change the concentration levels of each of the components and increase your risk of gallstones. So cirrhosis, you can get that. I think that's the lowest yield one. The Crohn's one by far here is the most important. You have to know the mechanism by which Crohn's causes gallstones, and this is the way it does it. Now let's talk about what conditions would cause increased cholesterol or bilirubin levels to concentrate the bile and cause gallstones. So the two subtypes of gallstones, if you haven't guessed already, are cholesterol stones and bilirubin stones. So let's first start by talking about cholesterol stones. So cholesterol gallstones, 80% of your gallstones are cholesterol stones. You could see a bunch of gallstones there. Most of them are radiolucent, which means if you take an X-ray, they're going to be translucent. You're not going to be able to see anything, which is why we do ultrasounds. They're yellow green in color. And here's, like I said, here's dozens of cholesterol gallstones. And the risk factors for cholesterol gallstones specifically are often referred to by the mnemonic of the 5 Fs. That's going to be females, people with obesity or fat people, fertile, 40, and first people. Okay, so let's talk about this common mnemonic that's used. So female, why would females be at higher risk of cholesterol gallstones? So females produce more estrogen, and estrogen is a driver of cholesterol synthesis. So that could increase your risk of cholesterol gallstones. For those people with obesity, the increased total body cholesterol can also be a driver to increasing the concentration of cholesterol in the bile. And another point that's related to this is that if you have somebody who's losing a lot of weight, that also mobilizes the cholesterol from the adipose tissue. And that'll temporarily increase the amount of cholesterol in your bloodstream, in your bile. And so then you're at a risk of gallstone formation during that time as well. So fertile stands for pregnancy. And what I want you to remember with pregnancy is that I'll keep it simple and just remember that pregnancy is basically a significant increase to your progesterone and estrogen levels. And we've talked about what both of these hormones do in the bile already. We've talked about estrogen right here promoting cholesterol synthesis. And earlier we discussed that progesterone can increase gallbladder stasis. So it's kind of like a double-edged sword there's two risk factors right there that can increase your risk of cholesterol gallstone formation. 40, the reason why this happens, cholesterol gallstones are most common around that age is because in your 40s to about the age of 60, your concentration of cholesterol in your bile is highest. And then before that, and even after that, the concentrations aren't as high. And because of these concentration changes over the lifespan, it's actually pretty rare to get gallstones as a very, very older person, like in your 70s. And in those populations, if somebody's developing gallstones for the first time, like much later in life, you should consider cancer as a potential driver that's kind of changing the concentrations in that region. And for first people or fair skin, so there's genetic factors that can increase the risk of gallstones in certain populations. So just keep that in mind. So those are the risk factors for cholesterol gallstones. Let's discuss bilirubin gallstones in some detail now. So the other 20% of gallstones are bilirubin gallstones, and these are caused by unconjugated bilirubin in our bile ducts. Remember that so far we've only talked about conjugated bilirubin making it into our bile ducts. As the red blood cells broke down, they released a ton of unconjugated bilirubin, and then our liver was able to conjugate them and put that conjugated bilirubin in the bile. You can see some gallstones right here, bilirubin gallstones. These are black gallstones. And that leads me to my next point, that there are two different types of bilirubin gallstones, black and brown pigment stones. And both of these are caused by different processes, but they both ultimately will lead to this unconjugated bilirubin in your bile ducts. So let's go over these different types of pigment stones. So black pigment stones arise due to excessive hemolysis. They're radio-opaque, which means you can actually pick these up on an X-ray. And the mnemonic here that I remember black versus brown gallstones, I remember black by when RBCs crack, the stones are black. So when you have a lot of hemolysis, I remember that as black pigment stones. Brown pigment stones, on the other hand, are because of recurrent infections in your biliary tree. These are radiolucent, so they're translucent. And again, the mnemonic I remember for this is when the infection goes down, the stones are brown. So let's show this in a picture format so it can reinforce it. So bilirubin stones in general are both caused by unconjugated bilirubin, making it into your bile duct. Black pigment stones form because of hemolysis. So if we have our red blood cells, imagine most of the time, any broken down unconjugated bilirubin will be converted to conjugated bilirubin. And so we don't have any risk of bilirubin gallstones in this case. However, if you have a ton of red blood cells that are all dying, they're just releasing a vast amount of unconjugated bilirubin. And what's going to happen is that unconjugated bilirubin is going to overwhelm the liver. And some of it can be conjugated, but a lot of it's going to stay unconjugated because there's just so much going through it at once. And some of that unconjugated bilirubin that makes it into your bile ducts can increase your risk of bilirubin gallstones, specifically the black pigmented stones. And remember, when RBCs crack, the stones are black. Brown pigment stones, on the other hand, are related to biliary tree infections. So what's happening here is that we have our unconjugated bilirubin. It gets conjugated. That conjugated bilirubin is a component of your bile, and that gets released. Everything so far has been completely normal physiology. What happens here, though, is that if you have an infection in your biliary tree, that bacteria that's in your biliary tree, whether it's in your gallbladder or your ducts directly, can deconjugate some of that conjugated bilirubin into unconjugated. And that can ultimately form brown pigmented stones. So remember, for the mnemonic for this, remember that when an infection goes down, the stones are brown. Another thing I just added here at the bottom, this you don't need to know this for step one, but liver disease can also cause bilirubin gallstones due to impaired conjugation. That should make some sense intuitively. If you can't conjugate it, then some more stones some more unconjugated bilirubin can get in there. But it actually forms a mixture of brown and black stones. It's a little bit more complicated than that. You do not need to know that for step one, but you definitely need to know how to tell the difference between a black and a brown pigment stone and what conditions cause it, hemolysis versus infection. And let's see, I even added a slide on this. Again, I don't think this is that important. This is just about how liver disease can basically cause more unconjugated, and it forms a mix of brown and black stones. Not tested ever on step one. I don't know why I kept that in there. Maybe just for completeness sake for you guys. Here's the slide that everything we've been talking about. I tried to condense it into one slide because it can be a little confusing sometimes. Remember that the risk factors, that gallbladder stasis, that imbalance where you have either low water, low bile salt or acid, or increased cholesterol or bilirubin, that increases your risk of all types of gallstones. Obviously, if you have increased cholesterol, that's going to increase your risk of cholesterol gallstones, and increased unconjugated bilirubin will increase these two. And then the pathogenesis is a little different. Cholesterol is naturally going to be related to increased cholesterol concentration in the bile. If we talk about black pigmented stones, that's because of increased unconjugated bilirubin making it into the bile, usually through something like hemolysis. Whereas brown pigment stones, not necessarily related to increased systemic bilirubin, it's more related to bacteria that exists that can deconjugate that bilirubin into unconjugated. So our risk factors for cholesterol stones were our 5 Fs. Anybody who's female, fat, fertile, 40, or first people / fair skin, those are all risk factors for cholesterol gallstones specifically. For black pigmented stones, we know that it's hemolysis, and our mnemonic was when RBCs crack, the stones are black. And for brown pigmented stones, infection in the biliary tree is a risk factor. And so when infection goes down, the stones are brown. I also included the radiographic findings of cholesterol being translucent, black is radio opaque, and brown is radiolucent. This is, I don't know if I was tested on the translucency of this, but just remember that black stones are the only ones that can be seen. So they're the only radio opaque stones. So we talked about the pathophysiology of how gallstones form, whether it's cholesterol or bilirubin stones. Now I want to talk about what that looks like in a clinical vignette. How are you going to see somebody who actually has gallstones? So most of the time, if you have a gallstone, you won't even realize it. Vast majority of cases are asymptomatic. But what can happen is that depending on where that gallstone is in your entire biliary tree, you can have complications, and those complications can be symptomatic. You can diagnose gallstones with a right upper quadrant ultrasound. As we discussed, most of the gallstones are radiolucent, so translucent, so you can't see them on X-ray, but right upper quadrant ultrasound can give you a pretty good idea of gallstones. Most of the time, this is treated with a cholecystectomy. You can live without your gallbladder, and the bile that you need to digest things can flow straight from your liver down into your duodenum if you have to. So cholecystectomy is the standard of care. Sometimes some patients are given ursodiol. Most of the time, this is just for patients who can't tolerate the surgery in the first place. And ursodiol works to decrease the cholesterol secretion into the bile. So again, that would help flip the scales, make the bile a little bit more dilute, and hopefully decrease the risk of gallstones. But like I said, cholecystectomy is the standard of care in most settings, especially if you're symptomatic. Thanks for watching. I hope you enjoyed the video. Please like, comment, and subscribe for more content.